Hello students, today we are going to discuss pharmacology of anti-asthmatic drugs. Now this video on pharmacology of anti-asthmatic drugs part 1 will give a complete, that is comprehensive overview of anti-asthmatic drugs. Now as we all know, asthma is a chronic inflammatory disease of respiratory tubes to the lungs that carry the air to and from the lungs. Asthma is characterized by narrowing of air passages causing difficulty in breathing. There is hypersensitivity of bronchial tree, and asthma is triggered by allergens like pollen, dust, smoke, cold, etc. Now very important to remember that asthma is reversible pulmonary obstructive disease, that is, there is difficulty in exhaling all the air in the lungs. Now classical symptoms of asthma are dyspnea, that is shortness of breath, difficulty in breathing, chest tightness that is caused due to the contraction of smooth muscles, cough mostly productive due to excess production of mucus, and wheezing, that is a whistling sound produced while breathing as the air passes through the narrowed respiratory tubes. Now let's study different categories of anti-asthmatic drugs and their fundamental mechanism by which they are useful in the management of asthma with the help of diagrams. Now first of all, allergen, let's say a dust particle is inhaled and it reaches a mucosa, that is the innermost lining of bronchial tubes made up of ciliated columnar epithelial cells. Now this allergen, it is processed by the dendritic cell. So dendritic cell processes the antigen and the antigen is presented by the dendritic cell to type 2 helper T cell. Now type 2 helper T cell further process the antigen and it produces inflammatory mediators, namely interleukin 4 and interleukin 5. Now interleukin 4 activates plasma cells which produce IgE antibodies. IgE antibodies bind to IgE Fc epsilon receptor 1 on the surface of mast cells, and this causes degranulation of mast cells and release of histamine and leukotrienes, that is the inflammatory mediators, and this results in the inflammation of bronchial tract. There is increase in the vascular permeability due to the dilation of blood vessels. There is increase in the mucus production and bronchoconstriction, that is the narrowing of respiratory tubes, that is a cardinal feature of asthma, which results in difficulty in breathing. Now anti-IgE antibody, that is a group of anti-asthmatic drugs like omalizumab that inhibit binding of IgE antibodies to IgE Fc epsilon receptor 1 on the surface of mast cells, thus inhibiting degranulation of mast cells and inhibiting the release of inflammatory mediators like leukotrienes and histamine. So omalizumab suppresses inflammation, that is the root cause of asthma. Now however, since it is a recombinant humanized monoclonal antibody against human immunoglobulin E, that is IgE, it has the potential to cause anaphylactic reaction which can be fatal, and apart from this it is very expensive also, and its use is reserved for resistant severe allergic asthma requiring frequent hospitalizations. Now next category of anti-asthmatic drugs are the mast cell stabilizers, for example sodium chromoglycate. Now these drugs, they cause impairment of mast cells chloride channels, inhibiting the influx of extracellular calcium inside the mast cells. Now due to the reduced availability of calcium, mast cell degranulation is inhibited, that is there is inhibition or there is reduction in the release of histamine, leukotrienes and other inflammatory mediators. However, the mechanism of action of these drugs is not very well established, and because of their poor efficacy, these drugs have been largely replaced by another category of anti-asthmatic drugs, that is the leukotriene antagonist, and these mast cell stabilizers are rarely used now. Now, another category of drugs are leukotriene modifiers, and this include cysteine leukotriene receptor 1 antagonist, that is montelukast and zafirlukast. Now, these drugs prevent the binding of leukotrienes to cysteine leukotriene receptor 1 on airway smooth muscles and other airway tissues, uh, preventing leukotrienes mediated inflammation and bronchoconstriction. Now, montelukast and zafirlukast are not used as the primary therapy. They are not used as a monotherapy. They are always used as an add-on therapy. They are added to inhaled corticosteroids in mild to moderate asthma. And these are also found to be useful in aspirin-induced asthma and exercise-induced asthma. Another type of leukotriene modifiers are 5-lipoxygenase inhibitors, that is xyluten, and this drug inhibits synthesis of leukotrienes, thus preventing leukotrienes mediated inflammation and bronchoconstriction. Now, use of xyluten is highly restricted because of its short half-life and its hepatotoxic potential, and therefore this drug is rarely used now. Now, another very important category of anti-asthmatic drugs are corticosteroids. Now, these are of two types: inhaled corticosteroids and oral and intravenous corticosteroids. Now, these drugs suppress inflammation, that is the root cause of asthma. Now, these drugs, that is corticosteroids, provide more complete and sustained symptomatic relief in asthma than other anti-asthmatic drugs. Now, corticosteroids suppress inflammatory genes, and thereby they suppress synthesis of inflammatory mediators. Now, inhaled corticosteroids like budesonide are the first line drugs in the treatment of mild to moderate asthma. Now, use of oral and intravenous steroids is reserved for severe asthma due to systemic side effects. Thus, all these category of drugs, that is IgE antibodies, for example, omalizumab, mast cell stabilizers, for example, sodium chromoglycate, leukotriene receptor antagonists, that is montelukast and zafirlukast, then 5-lipoxygenase inhibitor, that is xyluten, and corticosteroids. They suppress release or synthesis of inflammatory mediators, and thereby they suppress inflammation or they suppress mucosal inflammation in asthma. Very important to note that inhaled corticosteroids, they are the first line drugs for the treatment of mild to moderate asthma, and mast cell stabilizers, for example sodium chromoglycate and 5-lipoxygenase inhibitor, that is xyluten, are rarely used, and anti-IgE antibodies, that is omalizumab, is very expensive, and it also possesses the potential to cause anaphylactic reaction, and therefore its use is restricted to severe allergic asthma requiring frequent hospitalization. Now, apart from these anti-asthmatic drugs that suppress inflammation, there are bronchodilators. Now, bronchodilators are of three types: beta-2 agonist, then we have muscarinic receptor antagonist, and another type of bronchodilators, that is methyls thins, for example theophylline. So there are three types of bronchodilators. Beta-2 agonist, they are the most preferred, followed by muscarinic antagonist and theophylline. Now, beta-2 agonists are of two types. These are the short-acting beta-2 agonist and the long-acting beta-2 agonist. Now, beta-2 agonists like inhaled albuterol are short-acting beta-2 agonists. They produce bronchodilation within 5 minutes, and they are termed as rescue medication. They are effective in mild intermittent asthma and acute exacerbation. And these drugs, they stimulate beta-2 adrenergic receptors located on the smooth muscles of the walls of respiratory tubes, and they induce bronchodilation. And inhaled beta-2 agonists are most preferred bronchodilators. Now, second category of bronchodilators are antimuscarinics or anticholinergics, that is a muscarinic antagonist. Now, inhaled therapy is primarily used, and these are of two types: short-acting muscarinic agents, that is SAMAs, and long-acting muscarinic agents, that is LAMAs. Now, these drugs, for example, ipratropium, competitively block muscarinic M3 receptors located on the smooth muscles of the wall of respiratory tract. And by blocking muscarinic M3 receptors, these drugs induce bronchodilation. Now, as I have already discussed, beta-2 agonists are preferred over antimuscarinics, and antimuscarinics are not used as monotherapy. They are always used as adjuvants or add-on therapy to inhaled corticosteroids. Now, third category of bronchodilators are methyls thins, for example, theophylline. Now, these drugs induce bronchodilation by inhibiting phosphodiesterase isoenzymes, and these are the least preferred bronchodilators because of certain drawbacks. First of all, theophylline cannot be inhaled, it is always administered orally, and it is a poor bronchodilator compared to beta-2 agonist and antimuscarinics. It has a narrow margin of safety and a large number, it also shows large number of drug interactions, and high doses can produce problems or like cardiac arrhythmias and seizures, and therefore it is used as a third line treatment as add-on therapy in mild to moderate asthma, especially nocturnal asthma. Now let's quickly talk about additional important characteristic features of each category of anti-asthmatic drugs. And first type of bronchodilators are the beta-2 agonists. These are the inhaled bronchodilators. Primarily these are used as inhaled therapy. As discussed earlier, these are of two types: short-acting beta-2 agonists, that is the SABAs, and long-acting beta-2 agonists, that is the LABAs. Now, short-acting beta-2 agonist as well as a long-acting beta-2 agonist, as discussed earlier, they stimulate beta-2 adrenergic receptors on airway smooth muscles and induce bronchodilation. Now, short-acting beta-2 agonist, very important to note that these they produce their action within 5 minutes. They produce bronchodilation within 5 minutes, and therefore they provide very instant or quick relief in asthma, and therefore these drugs are used as rescue medications. These are the preferred bronchodilator. They are preferred over antimuscarinics and theophylline. These are used as and when required, and they are very useful for mild intermittent asthma and acute exacerbation. Talking about the long-acting beta-2 agonist, very important to note that these are used as maintenance therapy. That means they are used prophylactically for the prevention of attacks of asthma or exacerbations. Again, very important to note is the black box warning published in 2011, and as per FDA, long-acting beta-2 agonists, they should not be used alone. So they are used in combination with inhaled corticosteroids, and they are used for moderate to severe asthma. Now, detailed pharmacology of beta-2 agonist is covered in my video on pharmacology of anti-asthmatic drugs part 2. Now, second category of bronchodilators are antimuscarinics or anticholinergics. As discussed earlier, these are of two types: short-acting antimuscarinic agents, that is SAMAs, and long-acting antimuscarinic agents, that is LAMAs. And primarily these drugs are inhaled. Now, short-acting antimuscarinic agents, the most commonly used drug is ipratropium. Whereas in the case of LAMAs, the most primarily commonly used drug is the tiotropium. As discussed earlier, these drugs are the competitive inhibitors of muscarinic M3 receptors on airway smooth muscles. Now, as I have already told, these are less efficacious compared to beta-2 agonist. Short-acting antimuscarinic agents, they produce action in 15 to 30 minutes, and these are not used as monotherapy. They are used in combination with inhaled corticosteroids, and these SAMAs are useful in acute and chronic asthma, whereas LAMAs, that is a long-acting antimuscarinic agents, they are useful in moderate to severe asthma. Now, detailed pharmacology of antimuscarinic drugs has been covered in my video on pharmacology of anti-asthmatic drugs part 3. Now, the third type of bronchodilators are methyls thins, and these drugs are not used as inhalers. These drugs are used as oral slow release preparations. As discussed earlier, these are non-selective inhibitors of phosphodiesterase isoenzymes, and compared to other bronchodilators, their efficacy is less. However, these drugs, that is a theophylline, also exhibits anti-inflammatory effect. However, this effect of theophylline is not very well documented. It has a narrow margin of safety, and the high doses can cause cardiac arrhythmia and seizures. And it is used as a third line treatment. It is used as an add-on therapy in mild to moderate asthma, especially the nocturnal asthma. And detailed pharmacology, including the detailed mechanism of action of theophylline and how it exhibits anti-inflammatory effect, has been discussed in my video on anti-asthmatic drugs part 4. Now, next is a very important category of anti-asthmatic drugs, that is corticosteroids. Now, corticosteroids are of two types, inhalational, that is the inhaled corticosteroids, and oral and intravenous corticosteroids. And these drugs, they suppress inflammatory genes and they reduce the synthesis of inflammatory mediators. Now, detailed pharmacology, including the mechanism of action of corticosteroids, has been discussed in detail in my video on anti-asthmatic drugs part 5. Now, talking about the inhaled corticosteroids, very important to remember that inhaled corticosteroids are the first line treatment of asthma, and they are very useful in mild to moderate asthma. Now, talking about oral and intravenous corticosteroids like prednisone, prednisolone, methylprednisolone, these drugs, they are reserved for severe asthma, status asthmaticus and acute exacerbations, and their use is restricted due to systemic side effects. Now, corticosteroids being anti-inflammatory and immunosuppressive, they provide more complete and sustained symptomatic relief than other anti-asthmatic drugs. So, these are the most preferred of all the anti-asthmatic drugs in the symptomatic treatment of asthma. Now, next category of anti-asthmatic drugs are the leukotriene modifiers, and these drugs, they primarily suppress inflammation, and these are of two types, leukotriene antagonists, that is montelukast and zafirlukast, and 5-lipoxygenase inhibitors, that is xylutine. And both type of these drugs, they are administered orally, and their pharmacology has been discussed earlier. Leukotriene antagonists, they are used as adjuvant to inhaled corticosteroids in mild to moderate asthma, aspirin-induced asthma, and exercise-induced asthma. Now, while this xylutine, its use is highly restricted due to short duration of action and hepatotoxic potential. Now, the detailed pharmacology and the detailed mechanism of action of these drugs has been covered in my video on anti-asthmatic drugs part 6. Next category of drugs are the mast cell stabilizers, and these drugs, they suppress the inflammation, and these drugs are also administered orally. Example is the sodium chromoglycate. As discussed earlier, this drug prevents influx of extracellular calcium, which is required for the degranulation of mast cells. So, these drugs, they inhibit the degranulation of mast cells, thereby inhibiting the release of leukotrienes and histamine. However, as discussed earlier, these drugs are seldom used and they have been replaced by leukotriene receptor antagonist. And detailed pharmacology, including the detailed mechanism of action of sodium chromoglycate, has been covered in my video on anti-asthmatic drugs part 7. And another category of anti-asthmatic drugs are the anti-IgE antibodies, and these drugs also suppress inflammation. And as discussed earlier, these are recombinant humanized monoclonal antibody against IgE, and these are administered by subcutaneous injection. Example is the omalizumab. The mechanism has been discussed earlier also. This drug prevents binding of IgE antibodies to Fc epsilon receptor 1 on the surface of mast cells. However, the drug has a very high cost and it has potential for producing anaphylactic reaction, and therefore omalizumab has been reserved for severe allergic asthma requiring frequent hospitalization. And details of omalizumab, including its mechanism of action, has been covered in my video on anti-asthmatic drugs part 8. So this is in brief a comprehensive overview of anti-asthmatic drugs, and please note that this video is meant only for educational purpose. And if you like the video, if you find it useful, kindly like, subscribe and share this video. And you can ask your questions by writing in the comment section. Thanks for watching the video.